in the spirit of being comprehensive about the relapse refractory options, I do want to mention two very exciting new approaches that are on the horizon. We've heard a lot at this meeting about CAR T therapy. I do want to emphasize the excitement around bispecific T-cell engagers, and in particular a platform that's been developed, so-called 269, that Dr. Costa presented, that appears to have the convenience of being that much easier to deploy in the real-world setting. But there were other bispecific T-cell engagers that looked very promising, in my opinion. As I mentioned, the CAR T data were remarkable, particularly with some durability of response seen with certain CAR T platforms. In the same construct of immune therapy, I did also want to mention iberdomide, which is so-called CC220, and of course very early data on CC480. CC220 data has been presented, and that basically shows, very importantly, a solid 30-34% response rate overall in highly resistant patients, just as an oral therapy with dexamethasone. But what's so important is that this signal's seen in the penta-refractory patients as well. And just to share that this particular group of drugs, so-called CELMoDs, do appear to be particularly promising going forward. As we think about other exciting new agents that are emerging in the context of relapsed refractory disease, another very important BCMA-targeting approach that may be very important after CD38 failure, or I should stress, in patients in whom CD38 targeting approaches have failed them. That's, I think, a better way of saying it. In the BCMA space, we obviously have very exciting data about the antibody-drug conjugates. And at this meeting, there was a lot of correlative science presented around the excitement that we're seeing with the so-called antibody-drug conjugate GSK916 for short, which is named belamaf. This is an antibody-drug conjugate that integrates a warhead called auristatin. And we've had very interesting data from the first study, so-called DREAM-1, that was published, that showed around a 60% response rate in highly refractory patients. And importantly, in the daratumumab refractory subgroup, around 35 to 40%. So that's the true sort of penta-refractory group of patients. In DREAM-2, we were able to announce that the primary endpoint of the study had been met. This was in truly penta-refractory patients. And a late-breaking abstract that had been submitted unfortunately was not accepted because of the large phase 3 CANDOR study. But we will be making results from DREAM-2 fully available soon. The message for community oncologists is this is a once every 3-week infusion of an antibody-drug conjugate. There is corneal toxicity, but it is generally very manageable, and we're learning more about it and making that much less of an issue than it had been concerned to be in the past. And we're very pleased by the promise of this new approach. I think in the relapse refractory space at this meeting, we've had a lot of exciting data. We've focused in our discussion on antibody-based approaches. I do want to emphasize that beyond antibodies, there are lots of exciting small molecules in development. These include selinexor, which is already FDA approved, and there was tremendous data at the meeting looking at selinexor combined with pomalidomide and excellent outcomes in the relapsed refractory setting. Fascinatingly, there was data for patients in whom CAR T had failed them responding to selinexor. Similarly, a very exciting novel targeted cytotoxic called melflufen, which is aminopeptidase activated, demonstrated really nice data in terms of activity seen in, interestingly, very advanced patients with extramedullary disease. And we were reporting at this meeting on a number of outcomes and related studies to that. My point of illustrating these is to simply show that beyond the antibody approaches, there are multiple others available. I think the other point to share is that the options that exist in relapsed refractory myeloma also include already approved drugs like panobinostat, and in combination, these agents can be used to salvage patients, not least of which after some of these antibody and cellular therapy approaches have unfortunately not worked, and in that or run out of benefit. And I think that's the incredibly important message, which is that in the relapsed refractory space, there are multiple options. And I've only shared just a few examples to illustrate it. We touched earlier on the importance of venetoclax, and I think that just illustrates in a snapshot the numerous available treatment options that our patients have. So my concluding comment would really be relapsed refractory myeloma is becoming almost more like newly diagnosed myeloma was before. But with the caution that obviously relapse disease is one thing, relapsed refractory disease remains particularly challenging. Nonetheless, I think we're making continuous progress in improving outcome, and that's obviously very good news for our patients.